Great. Hello, everybody. We are entering our third session already this morning, moving along well. This is going to be on sort of the health tech industry space. We're going to bring up Vance Veneer, who is one of the faculty members at Stanford, who will join us in 1 second, who is going to be moderating this session. So give us 1 second to bring him up on stage, and then we'll get going with everything. We got a great list of panel who has a ton of experience in this space. And we're going to get going right now because I see Vance up on the screen. So take it away, Vance.
Good morning, everyone. I'm Vance Veneer. I will be your moderator for the panel. I have had the pleasure of being now an assistant clinical professor at Stanford for almost 20 years now. I think, quite honestly, that is my only qualification to be moderating this panel compared to the extraordinary talent that you're going to see showcased here. I always stand in awe of all the people Dan is always able to assemble each year. Quickly, from my own perspective, in addition to being an eMed doc, I have also been an entrepreneur, the CEO of two companies that were in genomics and molecular diagnostics. And then for the last 8 or 9 years, I have been an investor in healthcare services, investing a lot in physician practices, actually. But without further ado, I would like to go around the screen and have Tom, Austin, Unity, and Mudit introduce themselves. And Mudit, why don't you start first?
Fantastic. Well, good morning, everyone, and thanks for having me here. I'm Mudit. I'm one of the co-founders and CEO of a healthcare startup called Qventus. At Qventus, we automate care operations. So think of all the operational activities involved in surrounding the delivery of care. We do that across inpatient, surgery, and emergency departments and command center environments. All of these are based on sort of a AI-based real-time automation platform. Lots of experiences across health systems, large, small, safety net, academic, across these settings, and excited to have a chance to share some of our learnings and lessons with you guys today.
Very good. Unity.
Great to be here. Unity Stokes. I'm the co-founder and president of an organization called Startup Health. We've been one of the most active investors of early stage digital health over the past decade or so. We invest globally. We have made about 420 investments in 28 countries. So we have a very broad lens of the types of early stage digital health and health tech innovation that we see. And grateful to be here and looking forward to the discussion.
Very good. Tom.
Good morning or afternoon, depending on where you are. I'm Tom Castles. I am the president of Rock Health. Rock Health is a mission-oriented company focused on how we can leverage technology to make health massively better for all. We do that through three vehicles. One, Rock Health Capital, where we invest in early stage digital health companies. Two, rockhealth.org, where our not-for-profit arm, where we work with builders and entrepreneurs to focus on design and development of solutions that reach marginalized populations. And third, Rock Health Advisory, which I lead, which works with large enterprise healthcare companies on their own strategies for digital health in conjunction with their legacy businesses. And I also, prior to my time with Rock Health, worked in hospital and health system operations research at a company called the Advisory Board, and then tried my hand as an entrepreneur and was successful in identifying how not to be able to compete with Mudit in the automation space inside.
Very good. And last but not least, Austin.
Hi, everyone. Good to be here with you. I'm Austin Walters. I'm a co-founder and managing partner of Springtide Ventures. We're a Boston and Salt Lake City-based firm leading rounds at the seed through Series A stages for healthcare data innovation companies. We have a focus on applying Clay Christensen's theories of disruption to healthcare to democratize access to quality care. And we also have a focus on partnering with health systems and health plans, going into our second fund that we're investing out of now. The network of investors we built for our first fund, which we stood up in 2018, were largely serial health tech entrepreneurs. So we have a focus on markets that are underserved by traditional venture capital markets. So we've seen a lot of success in Utah, for example. We think Twin Cities, Research Triangle Park, North Carolina, Houston, Austin, Kansas City, et cetera, hold a lot of promise for health tech innovation on the digital front, and have a focus on recruiting team members and venture partners in these areas. So very happy to be here today. Looking forward to the conversation.
And we want the whole audience to know that even though this is a Stanford event, we do consider Austin still a good person, even though he went to Harvard as part of his education. But
thank you.
So thank you. It's our pleasure. Why don't we start with the investors first, and share around how have you invested in companies specifically that have emergency medicine or emergency department impact, and if there are actual examples you can share, I think that would be great. And let's go in reverse order. So Austin.
Yeah, so I think just share one example, and the focus for us, we're fairly agnostic as to how our companies are impacting healthcare, and what specialty within healthcare they're impacting. That said, we have over 20 medical specialties represented among our investor network, and we have 3, I think, who are emergency medicine physician entrepreneurs. And so I think naturally that has come with some deal flow. And I'd like to talk about one company that we've invested in that I think has a lot of applicability to the emergency room environment and emergency medicine, whether it's in the room or not, which we'll talk about later. A company called Wellsheet. This is a New York company that is really the leading fire standards data interchangeability company from my perspective, that is very interestingly becoming a kind of what we think of as an EHR 2.0. So EHRs, in our view, historically have served as systems of data storage, systems of display, and systems of action, all 3. We think that with modern user interfaces, that we can leave traditional EHR systems as systems of storage and systems of record on the back end only, and provide much better systems of display and action on the front end. And so our thesis for Wellsheet is to become a new front end for electronic health record interaction. It's a big vision. There are several benefits to this that I'll bucket into two areas for emergency medicine. For example, one is that it decreases the number of clicks as a clinician's interacting with the system of record by an order of magnitude, and so saves a lot of time. Secondly, they have plugged into a lot of HIE data from the payer side that's value-based information to pipe that information to the provider at point of care real time, so that value-based decisions can be made. I think we could have a longer discussion about how those decisions can be made in the context of emergency care, but we believe it's important. And so having a broader view of a patient and a patient's history, we think platforms like WellSheet can be a big part of that.
Very good. Tom, how about you next?
Sure. I think I will. I'll be brief. I think one of the companies that we think very, very highly of is an emergency medicine telemedicine company that is actually covering nursing homes and independent living facilities to actually triage whether certain cases ought to require a trip to the emergency department or not. Historically, those companies have been, historically the ED has been the, I would say, default when there was any concern whatsoever, and probably not to the betterment of the seniors that are living. I think we can all agree that the hospital is probably the most dangerous place to put someone who is frail and elderly. So Tembo is doing really exciting work to make sure that only truly emergent cases that require hospital-based emergency services are taking place there. So kind of almost forward locating into senior living and extended nursing facilities.
As an investor in senior living communities across the U.S., I can certainly vouch for how potentially valuable that technology is. One senior living directors take most of their day to think about two things: one, how to bring new members into a senior living community, but as importantly, how to keep them there, how to keep them safe, how to not have to have them transitioned out. And so certainly any kind of triage that helps that retention, I can imagine, would be met with open arms. Unity, how about you?
All right. One of the things I think is so exciting today is really the breadth and diversity of types of solutions that I think are emerging. So even across our own portfolio, I think of companies like Beyond Lucid and their MetaView technology, which is really connecting in real time the ambulance, the EMT or fire department with the ER. And they are using technology that NASA uses to connect with people in space, so that even in remote areas, like in the middle of the desert, where there's no cell service or Wi-Fi, there are links to the ER. And then I think about the real-time diagnostics innovation that's going on that really bring new diagnostic tools out into the field, or even into the home or clinics that can then link up with the ER. Companies like Adar Health that has sort of a tricorder affordable device that people can breathe into and assess a lot of different things. But then there's things that we don't think of, like logistics. Companies that are using new logistics systems to get blood or organs more effectively. We've got a company called MediOps doing that. Quicker Care is doing a reservation system for ER, so people can book reservations in advance of either urgent care or into the ER and not have to go and wait for 6 hours, but actually do that from home and have a more efficient process there. Care Team is doing care coordination from the ER to all of the other care planners that may be involved with a particular patient. And then I think one of the things maybe we'll talk about throughout the conversation is how the ER or more emergency medicine is coming outside of the walls of the hospital because of new innovation that's happening.
Now, does your first company mean that our poor charge nurses are going to be getting medic radio calls from Elon Musk's space station?
Well,
it's hard enough to handle.
Yeah, I mean, connectivity is, I mean, I was even just having problems here with my own Wi-Fi. I'm in Berkeley, dropping off of this conversation, right? So when it's a life or death situation and seconds matter, having access to the medical record that's accurate from a remote area, having the ER docs actually understand what the situation is in the field, and making that whole process streamlined is saving lives. I mean, these are really extraordinary innovations that are leveraging tools and technologies that have been used in other industries like space.
Very good. Does Cuventus at all touch the emergency department?
Yeah, we do, and that's actually where we started doing our work in. As you know, I talked about care operations. There's one place in the hospital that is the best microcosm of all the chaos that surrounds delivery of care and people who are highly motivated to get it done. It's in the ED. We work a lot with EDs, as this audience knows well. There's no average day in the ED, yet almost everything we do from a plan standpoint, process standpoint, flow standpoint is planned around quote unquote average days. So we built a lot of technology around both optimizing for variation that we can predict and then allowing health systems to in the moment flex for what was not predictable in advance. And so thinking of those two buckets, first understanding sort of where and how you manage your staffing, how do you put the right pieces in place, how do you set your different areas and flows of the patients, the low acuity patients versus the high acuity patients, so they can go through the right environments. And then secondly, in an environment that changes so rapidly, how do you dynamically understand what bottlenecks stand in the way of slowing the ED down and slowing the patients from being taken care of? So being able to understand on the fly what are those bottlenecks, those rate limiting steps, and understanding those and being able to escalate those and have a group react to that has been another area that has been really valuable for health systems that we work with. The other piece I'd say is, especially right now, what we are seeing, the EDs in the last 2 years have gone through a pretty massive shift where in the beginning of the pandemic, there was substantive drops in volumes, of course, and then more recently, massive increases in acuity of cases that EDs are having to see. And with the staffing shortages across the board, a big gap in patients that can go upstairs into the units, and how much time that is taking and how much boarding that's coming out of it. So we've been also focusing a lot on that flow, the flow on the inpatient side. We've seen tremendous results there as well. I think last year across the customer base, we eliminated about 2 million hours of excess time spent in units upstairs. Those are basically effectively boarding hours that you would have had to face in the ED, and of course also very costly, and also an area which patients don't like to spend time in the hospital past when they need to clinically do. So those are a couple of ways we work with health system EDs across the country, and I think EDs are in a operationally and otherwise a time of change, massive change, both in their role within the health system, in that they're seeing much severer acuity than we have seen in the past, but also in their role in shaping the care that happens and shaping the pathways that the patients take in accessing care.
Very good. So, our audience has a lot of very entrepreneurial physicians, and especially emergency medicine physicians in it, I think. And certainly a question I get very commonly asked is how can those folks get involved in innovation or the startup community? And so for Mudit and Unity, wondering if you could share some of the specific ways that you've gotten ED docs involved in your companies. Unity, why don't you go first?
Yeah. one of the trends that has been emerging that we've seen is the rise of what we call the doctorpreneur. So MDs or clinicians who are becoming entrepreneurs themselves. They're on the front lines. They see and know firsthand the need or many needs. So at Startup Health, we try to really integrate physicians, many ER docs, right into starting with the review process of companies that or innovations we're looking at to potentially invest. So first, bringing them into the review process. We then invite many ER docs to be part of the trialing or development of innovation. Many of our portfolio companies hire ER docs either as advisors or chief medical officers, as an example, or even product development officers in the build cycle. So there's just, I think, a lot of value of integrating what's going on in tech science with the front lines, where a lot of the care and understanding of what's truly needed, of how workflows go, and really integrating that into the design build process as early stage innovations being developed.
Very good. Mudit.
Yeah, I think we've used clinicians and specifically ED physicians in multiple capacities across the company. We found them to be I think ED physicians in particular have both an ability to have a breadth of understanding of clinical conditions and clinical pathways that patients often have to take. But I would also say like a kind of a requisite thinking process of finding quick solutions to problems in front of them that aligns really well with what we need from a startup sort of product development standpoint. So the two ways we've used them predominantly, one is, or maybe three ways actually. One has been there's key leaders, key ED physician leaders that we've had work with us in imagining what the next set of problems that both EDs will face and health systems more broadly will face. Secondly, we actually have people in the company who are clinical product designers. So these are people who are, because of just like Unity was saying, the understanding of both the clinical pathways, the workflows, and the situation on the ground, they form as excellent partners to the product and engineering teams in both designing solutions, designing workflows, designing machine learning algorithms alongside our R&D teams, and have been really core to the process of both developing new products and taking existing products and continually improving and iterating on them. And then the third piece is in our clinical operations teams. These are teams that actually go on the ground with customers, take the products that we built, also realizing and recognizing that there's often process change or behavior change that is associated with that, and making those customers successful on the ground as well. So we've seen across the life cycle there being lots and lots of opportunities for physicians, and they've done made a tremendous difference to each of those processes and shortening the cycle time of a team that might otherwise take longer to hold on the right intuition and on the places to focus on.
Terrific. Next question. I think when most people hear about medical innovation, they assume it means innovation around drugs, diagnostics, devices. But what I would actually say is that I think the most impactful innovation that's been happening in the last 5 to 7 years is around delivery models. And Stanford itself has actually been a real pioneer in setting up an institution some years back that has really studied delivery innovation and cost effectiveness. And so I know this is a question that everyone on this panel feels really passionate about, and the question is this: what are models that you are seeing that are disrupting or extending, the traditional places that care is delivered, and how are you seeing emergency medicine get involved in that? And so maybe we'll start with Tom first.
Sure. I think there was a question in the comments section about, emergency medicine improvement being kind of not an area where VCs want to move. But if you think about the movement toward having care in the home. That absolutely 100% is tied into emergency medicine. Improving the ability to triage to an actual team that can be trusted to provide observational level care or med surg level care in the home cannot take place without strong decisions being made and stood behind by emergency medicine physicians. The other area I would talk about, this, not to pat anybody on the back on my own panel, but one of the things that Qventus does, and why the emergency room is where we start, is that of all of the practices today in medicine, the strain and stress of the emergency room is requiring more load balance, and there are companies, Qventus and others, who are focusing on using machine learning to really understand how do we keep folks in the emergency room, yes, productive, but not burning them out. And frankly, any investment in clinical care models that isn't focused on the issue of burnout is something that is a red flag for me as an advisor to our fund, to say you're barking up the wrong tree. But the big piece that I would say is, and Unity spoke to it very very well before, emergency care and immediate care is moving out into the community and into the home and into living spaces, and that requires folks who are well trained in understanding the decision tree that tells us what is the safest next best action for a patient, and that puts emergency physicians right in the center of all these new business and care models that you're talking about.
Very good. Austin.
Yes. So I would start with a question first on this of what percentage of ED visits are unnecessary or avoidable in a given emergency room. And from what I've seen, which is the Boston Medical Center, we've met with about this, their emergency department. It's a health system hospital, south of Boston. It's sort of 70 to 80% that they estimated. And so I want to just touch on things we're seeing as far as what is unavoidable and necessary, right? I mean, for certain trauma situations, right, you're never going to digitize care for that, like surgery, right? So the ED needs to be there. So I'll talk about those types of situations, but where I think we see a lot of innovation happening that is really extending emergency care to kind of earlier in the process, right? As the patient, maybe at point of trauma, right? Or closer to the point of trauma coming into the ED. And then secondly, talk about application areas we see for rerouting patients to more appropriate places. And so for those that are unavoidable, where we think the ED can extend itself to earlier in the process. I'd point to handheld ultrasound as a great example in my mind of this. We're not investing in medical devices at Springtide per se, so we unfortunately don't have a point of care ultrasound investment. But the company that I was part of before starting Springtide in 2018 is called Echonos. It's a competitor to Butterfly, the GE V-Scan device, and others. And we were licensing AI algorithms. We'd raised 100 million in venture money from OKR off the balance sheet to bring ultrasound to primary care. And we were licensing AI algorithms from companies to help primary care users of ultrasound to interpret what it is they were seeing on the screen. And so I think AI has tremendous potential to help acquire the right image and then interpret it real time, which can be useful, I think, at point of trauma. So for fast responders, right? They're not ED physicians, but telemedically and algorithmically, we can help triage patients more effectively at point of trauma. For this vast second category of things that are maybe avoidable or unnecessary to deliver care for in the ED, I think a lot of it is related to social determinants of health and or chronic conditions. And so homelessness, loneliness, mental health disorders, diabetes, COPD, thyroid disorders, polypharmacy issues, right, for the elderly. These are all areas where we have investments. And so these areas of care delivery innovation, I completely agree with your comment, Vance, that this is a huge area of innovation right now. And so we think that if these patients are cared for properly, we can avoid a lot of unnecessary ED visits. So that this would be a good thing for the ED, which should be reserved for true emergent situations.
Yeah, I'm reminded of that kind of real world problems that patients have for access and where to get it. I'm reminded of a story about 15 or 20 years ago. I had a associate who had just come out of business school and had worked at Google, and I asked her, what do you think the most important problem is in healthcare right now for patients? And she said, data illiquidity. It's terrible that they can't port their data. It was a very esoteric answer. And, I didn't say anything, but my own quiet thought was actually, it's probably the patients I saw last night that had nowhere to go and they couldn't afford the bill in the first place. And that's why I think delivery innovation is just so important for the country. Unity, how about yourself?
I couldn't agree more with what Austin was saying. I think if we think about what's happening in the big shift, it's really bringing a lot of the tools, the very often once expensive tools like an ultrasound, and even bringing them into remote villages, turning the phone into a clinical device in remote places. So people themselves, in cases of emergencies, can have a real-time hookup for something like a pregnancy, but still be connecting to a care provider that may be hundreds of miles away. We're seeing this across diagnostics. We're seeing this with being able to deliver medications via drone, for example, or different health tools to remote areas. So I think the overarching trend is just bringing a lot of the innovation where people had to go into the ER, as Austin was saying, not necessarily for a trauma situation, but for some other need. And with new, more affordable diagnostics or delivery mechanisms, we can now do that in other locations. I think of our company Oxytone, which has a wireless mobile pulse oximeter. If we all remembered, or if whoever read Steve Jobs' book, at the end of the book, it's all about how he's bound by a pulse ox to his hospital bed because of all of the wires and stuff. Now with new mobile tools and diagnostics, people can stay in their own home and still be connected to the ER and to their doctors, and not necessarily have to go back and forth, but still be monitored appropriately by their care providers. So I think the links between the ER or emergency departments or different types of care providers and wherever the patient is going to prevent a lot of emergency room visits, and free up the ER for other types of trauma situations in many cases. So I think this is a global opportunity as well. And this is relevant in cities, but it's also relevant throughout remote areas and other parts of the world. As these new sensors, new diagnostics, and new delivery mechanisms make it more affordable to deliver this type of expensive care.
Great. So I see we have 13 minutes left, and I know Dan wanted us to open to the audience for questions. Mudit, do you have any other answer for this question to share to close it out before we go to Q&A?
I agree with what everyone is saying. I'll just maybe share a brief thought or two, which is I agree that the EDs are often used as a access of last resort, and I think leading to a lot of the unnecessary care everyone was pointing out to. But I also find that those are moments for the ED physicians and others to, in some way, shape the care patterns and use them as education moments. So whether it's the right level of care, whether it's patients who don't need to spend time in the hospital can go directly to SNF, or patients who understand how to take care of the chronic conditions through the various tools the panel members were mentioning. I think there's a role to play in those unnecessary visits in the EDs and shaping the care patterns through that. So that's the only other piece that I might mention.
Great. Well, we'd like to, in our last 11 minutes here, open up to questions from the audience. So as we can monitor the comment section for the questions. There was an earlier question that maybe I can read to get us kicked off, which was somebody said that, could the investors comment? I've heard venture capitalists say no one wants to spend money on EM improvement. It's a loss leader for acute care. The investment dollars go to highly profitable departments like surgery or radiology. Would any of you like to tackle that one?
I think, if there was any shining bright spots of what we've learned during COVID is health systems, hospitals are rethinking about how they're integrating technology into a more holistic way of their whole system. So I think we're starting to see CEOs of these systems, the CIOs, the whole infrastructure rethink about how technology, whether it's telehealth or AI or all the way up the stack, gets re-looked at in new ways to try to bring those costs down. I think the technology of today is way more cost effective and efficient than even 5 years ago. So I think there's an opportunity here for a fresh look. And I think the CEOs we're talking to are trying to find ways to save money throughout. And this is one, the EM, emergency medicine overall, is a big cost in a lot of cases. So there's an opportunity to really bring the costs down by leveraging technology.
Great. We have a question from Dan Imler. A large blocker I've seen with health tech startups have been access to work with relatively large healthcare systems and their data sets. How can they break through that differential in power? Tom, this must come a lot in Rock Health's companies. What are your thoughts?
Yeah. So there's a company that that recently raised, and unfortunately we weren't in the round, called M-Disrupt. And the insight behind M-Disrupt, which I personally think is really strong, is that actually the worst place you can go to break in and get real world evidence on your health tech innovations is an academic medical center. Because the politics, the complexities, and frankly, the physicians who want to step out front and use a new technology don't reside there. And so what M-Disrupt is organized to do is to actually connect non-academic physicians who are early adopters of technology with startups and growth stage digital health companies to actually get that in the market experience to build up a record of outcomes. And Ruby Galradab, who's the founder there, I personally think has drawn out this insight that if all you're doing is going to every AMC, I think you're limiting your chances to decisions that are in some cases more political than they are logical or evidence-based.
Thank you. Jared Conley is asking a question which I will steer towards Austin given his earlier comments. Of note, there's a lot of confusion and misunderstanding on what percent of ED visits are avoidable. I'm just paraphrasing here. It could be lower than 5%, depending on how it's defined. What is being done in the investor community to understand where the real opportunities are to better match provision of care with site of care?
Yeah. Hi, Jared. If you're still here, good to hear from you. I think it probably does vary quite a lot from emergency department to emergency department. For us, I have to admit we haven't systematically come up with a way to or have undertaken a project to better match sites of care with care needs. For us, it's been more driven by our due diligence process in companies that we find, and so we're a post-revenue investor. We don't care how much revenue a venture has, but we want there to be a customer or two or three at least that are paying a fair price. And a fair price means that it's a price that creates value for the customer, usually a provider, organization, or payer, and the company itself. And then we want to speak with those customers to understand why they have purchased this solution. And we use a methodology that was popularized by Clay Christensen called jobs to be done. And it's really the concept is that everything that we buy in life, we're hiring that thing to do a job that we have to be done. And so when we speak with a health system, for example, or an emergency department, or any customer, right, the purchaser of a solution we're considering investing in, we're trying to understand what their jobs to be done are, and we're trying to invest in solutions that address jobs that are commonly held in the market, poorly addressed by existing solutions, and acutely felt. And unless the solution is addressing a set of jobs that are widely held enough, acutely felt enough, and poorly addressed enough, it probably won't succeed, at least in a big way. So that's the approach we take, but it's really kind of on a company by company basis. I like the idea of a broader survey. That would be our current approach.
And Jared, I can add a little bit to this. For many years, our own fund has been investing in the areas of value-based care, and specifically large primary care groups that take full global capitated risk from Medicare Advantage plans. And in fact, we also own a Medicare Advantage plan, and it's been fascinating to watch the companies and the physician leadership of these groups attack the problem of site of service, because it is one of the biggest levers they have to pull in order to kind of reduce medical expense. And so as an example, these companies will actually buy or lease SNF beds because there's a subset of admissions that are better detoured towards going to the SNF instead of staying in the hospital. Or they push to have surgeries done in the outpatient setting because literally the same cardiologist doing the same cath on the same patient costs 50% less if it's done in an ASC versus a hospital. Or they invest a lot in technologies and dashboards that are reviewed every morning to make sure that the patient with an ankle sprain has expanded clinical access to show up there. Same thing with pink eye as opposed to the ER. And so there's a service component there around having clinics open on Saturdays and Sundays. So I would actually argue, and they're very large companies that have now been taken public in this model, like Agilon Health and P3, which is our company, and Oak Street and soon to be Village MD. And so I actually personally think any investors in any companies in those models are probably where the most site of service innovation is going to be happening, because that's what kind of helps them reduce med expense. 12:18, 2 minutes to go. We have multiple questions here. Let me just pick the final one from Rochelle John. What work are startups doing to ensure the technology and services are billable per CMS guidelines for the physician service line, if not performed in EM? Any question that has to do with reimbursement for innovation is an absolutely perfect question, because a lot of companies have perfect science and technology and they still don't succeed if they haven't solved the reimbursement question. So anyone on the panel, welcome to answer this question.
I would just, I mentioned our company Beyond Lucid and their MediView technology. One of the things that often happens is the records get lost of all the things that happened from the ambulance all the way to the ER, and it's not tracked properly or documented properly for that reimbursement. So that whole, by leveraging technology to manage that whole process, it makes more efficient the whole billable process from the beginning interactions with the patient all the way through the visit, just by documenting things properly. So there are, I think, the good point is it's not just about the technology, it's about the workflows and the billing reimbursement flows that need to tie into these innovations that go beyond just technology.
Very good. Well, it's 12:20. I want to be respectful of our panelists and the audience time and end right on time here. Thank you to the organizers for inviting us to the panel with you. Good afternoon, everyone.
Thank you.
Thank you.
Everyone.
Thank you.
So I'm going to go ahead and outro us. The next is a break, actually. We have a little break. And then coming back will be time for you to make a decision whether you want to continue on with the panel discussions, where we'll be talking about devices, or can join the pitch competition. And again, the pitch competition will have 6 different companies, different startups that are going to be presenting to a group of 5 different judges. And at the end, we'll be crowning a winner of our StEMi X 2022 Pitch'em competition. So it's very prestigious, very prestigious. I just wanted to comment really quickly on one of the comments here about potentially having an EM or some kind of clinician as well on this panel. I think that was a great idea. When we had first titled this panel, I was thinking, oh, it's a pretty narrow topic, how startups are impacting emergency medicine. But now, just after having gone through the panel, I realized it's a very, very broad topic, and we could have honed in a lot more had we really wanted to, because it's a far-ranging topic. And obviously, with our panelists, with their wealth of knowledge, we had a lot of different great points that we could have really gone more in depth on. So something to think about for next year, and maybe we'll be talking about Web3 and blockchain or something of that nature next year. Stay tuned. Go enjoy a break, do a little stretching, and get something to eat. Whatever you need to do, make some calls, feed the baby, walk the dog, and we'll see you when you guys come back. Again, you get to choose between either the pitch 'em competition, or the next panel, which is devices in emergency medicine. Cool. See you then.